For this discussion today, we have Dr. John Vierling. He is the Professor of Medicine and Surgery, Chief of Hepatology, and Doctor of Advanced Liver Therapies at Baylor College of Medicine. As you saw in the Whova app probably, he has a lot of interesting and awesome areas that we're going to be covering for today as well. You know, focusing on the key diagnostic criteria, discussing the role of biopsy and alternatives, non-invasive ways, as well as looking at the criteria of the overlap and those types of things. And lastly, but of course everybody's interest, is standard of care and new phase 3 that are happening as well. So I'd like you to all welcome Dr. John Vierling. Here's the slide advance.
Thank you, Tom. Well, it's a real pleasure to be here with old friends, and new faces. I first want to thank Carol Roberts and Tom Drain for all their hard work on your behalf. And it's been a pleasure to be associated with this organization for multiple decades. And I'll add one interesting note that I don't think was discussed, and that is the PBCers collectively have been instrumental in our understanding of potential risk factors. So Keith Lindor, Eric Gershwin, and I worked with the PBCers through surveys to have some of the most credible data regarding early life experiences and potential risk factors that are environmental triggers for autoimmunity. And that is another powerful platform for this organization, is participation as a group effort in epidemiologic research. So I thank all those that did participate and all those that may participate in the future in this field. It's my pleasure to talk about diagnosis and management with an emphasis on what's new. And much has changed. This lecture 2 years ago would have been promissory with trials that had not yet been fully completed. But I'm here to tell you about trials that have been completed, and you're going to see some new data. And indeed, the dates for potential FDA approvals for the two newest therapies, as second-line therapies, is this summer. So this is a major advance. These are my disclosures. I work with a lot of entities in research support, scientific advisor to many, and indeed will mention some off-label uses of drugs. So I want to disclose all that to you. So let's start at the beginning. This is your liver. It has a portal vein. That makes it unique. Of all the organs of your body, it's the only one that gets a blood supply from a vein as well as an artery. That vein is draining all the immunologic substances from the spleen and everything that's inside your gut and in the wall of your gut. And it all comes back to the liver in that portal vein. So it is a big environmental exposure for nutrients, for toxins, for any number of substances that are influencing. It has an artery. All organs need arterial blood supply with oxygen-rich blood. And it also has a biliary tract, which you're all aware of because that's the nature of PBC. And it's a branching system, as you see. When you do a cross-section and look a little bit more in detail, you find that these three elements lie within a tissue space. It's a little bit like a conduit in the wall where you put your wiring through to go room to room. This includes the bile duct, accompanied by an artery and the portal vein. The key here is the artery and the bile duct are always together. And that is how we can tell if a bile duct's been destroyed. In a biopsy, we can see an artery, but we can't see the paired bile duct. That becomes critical in a disease like PBC. Now, in a healthy liver, the bile duct has no inflammation existing around it. Those three elements are lying there just as shown here. But in PBC livers, inflammatory destruction of bile ducts by white blood cells called lymphocytes causes upstream retention of toxic bile acids, which we call cholestasis. Chola is Greek for bile, stasis is stasis. The bile flow is disrupted when you change and destroy the channel through which it's flowing, so upstream the concentrations will build up. Now, PBC livers involve inflammatory destruction that involves only the small to medium caliber bile ducts. And this is curious. We do not have an explanation for it. but it means that our targets have to be refined in terms of the physiology and the biology of these particular duct sizes. So now we can all summarize this with the definition of PBC as a rare autoimmune disease with lymphocytic destruction of small and medium caliber bile ducts that results in progressive cholestasis with upstream retention of toxic bile acids. This disease occurs globally in all races and ethnicities, and it afflicts adults, but not children. That makes it unique among other autoimmune diseases, all of which have childhood presentations. Other autoimmune diseases are common. In about 50% of people with PBC will have one or more. And this tends to be autoimmune hypothyroidism, beginning with thyroiditis, Sjogren's syndrome, sometimes referred to by clinicians as a Sika syndrome, and other things like systemic sclerosis, Raynaud's phenomenon, etc. The female to male ratio makes it a predominantly female disease, but very interestingly, worldwide, that ratio is moving down to 4 to 1. That means many more men are being diagnosed now worldwide. And we've summarized this in something that's under review for a journal called Lancet, in a review looking at worldwide data. The incidence is about 60 persons per million population per year. So this is a rare disease by that number. The prevalence, however, is much greater, 350 per million. And the prevalence is all those that are living with PBC after diagnosis. So there's an input with the yearly incidence, and then people continue to live. So there's a fair number of people with this disease. But most importantly, in the United States, about 1 in 1,000 women over the age of 40 are estimated to have this disease or will develop it. And the prevalence is increasing due to better patient survival with ursodeoxycholic acid treatment. And that treatment era began with FDA approval in 1995, though many clinicians, myself included, were using it from the late 1980s and early 1990s because we had access to an off-label use of a drug, ursodeoxycholic UDCA, for gallstone dissolution, and we applied it for PBC. Finally, orthotopic liver transplantation, OLT, has a decreasing need because of this increasing survival due to oral medications, but it remains an important indication among females. And we don't want to forget that because the attention is now shifting toward the metabolic dysfunction associated steatotic liver disease. What a mouthful. This is what you used to call non-alcoholic steatohepatitis, but changed the nomenclature on us all. And that is kind of ramping up as well as alcohol-related liver disease. So PBC in women is still right up there. Now we're going to turn to diagnostic criteria. And we're going to talk about those that have antimitochondrial antibody or AMA positivity and those that do not. I've got 4 criteria here, and 3 of them are boxed. Let's deal with the 4th first. When anyone has a rise in alkaline phosphatase enzymes accompanied by GGT, this tells us the alkaline phosphatase is coming from these cells in the liver, hepatobiliary origin. There is alkaline phosphatase that can come from bone, and people with bone disease might have an elevation for that reason. All growing children, for example, have an abnormal adult level because they're growing and their bones are contributing alkaline phosphatase. But when you have that alkaline phosphatase of hepatobiliary origin, your first goal is using imaging, show that there's no obstruction, mechanical obstruction of the bile ducts. So we kind of check that box, and then we move to, is there AMA positivity? And then, is there a need for a compatible liver biopsy? Well, if you have the cholestatic pattern of enzymes and you have AMA positivity, that seals the diagnosis. You need only 2 out of 3, and you don't need a liver biopsy. But if your antimitochondrial antibody is negative, then to get 2 out of 3, you would need a biopsy plus your cholestatic pattern. But this is also changing. And the way it's changing is, although AMA is very, very common in this disease, depending upon the assay used to test it, anti-nuclear antibodies, not mitochondrial, but anti-nuclear antibodies, occur in over half of patients with PBC, along with AMA. For AMA negatives, they're the dominant ones. They're the positive group. And you can see two of them, the GP210 nuclear rim pattern on the top right, and SP100, this multiple nuclear dot patterns. These are commercially available. And when you test for those, these are PBC specific. So they're the equivalent, really, of AMA positivity in those that are AMA negative. Now, if we do and add others that are not yet commercially available that I've listed here, we can now account for over 3/4 of AMA negative patients. And so we could diagnose them serologically without a biopsy. Now, other autoantibodies also occur that are associated in general with liver diseases. Anti-smooth muscle and rheumatoid factor is relatively common. So the conclusion here is that AMA positivity is now equal to GP210 or SP100 positivity for a diagnosis not requiring liver biopsy. Now, there's a conundrum here because the liver biopsy is often helpful in establishing the stage of disease. What is the amount of inflammation? What is the amount of scarring reaction, which we call fibrosis? But we have non-invasive ways to look at that. And the most popular and the most well-studied is using the FibroScan, which is vibration-controlled transient elastography. On the left cartoon, you see CAP. This stands for computer-assisted parameter. And this is a measurement that will allow us to understand whether there's fat in the liver. That becomes very important because 34% of American adults also have fat in their liver. They have this metabolic dysfunction-associated steatotic liver disease, again, the mouthful, MASLD. And if they have inflammation associated with that, which is called MASH, then they have another liver disease. So there's a possible contribution. And we have to be aware of that. So we like the CAP-assisted FibroScan because we can see if there's fat or not, yes or no, and if yes, how much. And it also gives liver stiffness, which is an indicator of fibrosis stage. Now, in PBC at the top right, you can see boxed in the green that the fibrosis 0 to 1 stage can be clearly differentiated from fibrosis F4, which is cirrhosis of the liver. But in between, there's a lot of overlap. So we don't really rely on a specific number other than as guidance, where we consider severe fibrosis in PBC patients to be greater than 10.7 kilopascals. That's the unit of measure for stiffness, and cirrhosis to be essentially 17. Now, inflammation and fibrosis are co-measured as stiffness. So it's fibro-inflammatory measurement. PBC is inflammatory disease. We just discussed that. So these numbers have kicked up from other numbers that are used for other liver diseases to accommodate inflammation and not overreact and inaccurately characterize a patient. Now, this is a real conundrum. This is the PBC autoimmune hepatitis overlap syndrome. Often, too often, this is a misdiagnosis that occurs without application of key diagnostic criteria. The left cartoon shows that this overlap is reported originally at about 1 to 4%, and then rose to 10%. And in some series of individual medical centers, predominantly in Europe, they have it as high as 15%. And that would suggest that the biology has somehow really changed over a relatively short period of decades, which I disbelieve. And the reason that we're having this debate is we don't have a marker in blood or other tissues or urine that will tell us that the pathogenic process of PBC is coexisting with the pathogenic process of autoimmune hepatitis in the same patient. We need that biomarker. We don't have it. So what do? We recommend in our guidelines using the PARS criteria for PBC-AIH overlap. The PBC component is essentially what I've just told you about PBC diagnosis. But the autoimmune hepatitis component requires a liver biopsy that shows moderate to severe interface hepatitis. What is that? That is that portal tract contained within the conduit I showed you. If the inflammation is coming outside the walls of that conduit into the liver cells, that's called interface hepatitis. And it has to be moderate to severe. And we talk about that as being 50% or more of the circumference of that portal tract is involved with this penetration of cells outside. In addition, you have to have either one of the following: elevated IgG 2 times the upper limit of normal, smooth muscle antibody at a detectable titer, and an ALT, or an ALT, 5 times the upper limit of normal, which is around 200 units per liter. Now, if you use criteria like that, in the Mayo Clinic cohort that was published, they looked at 1,476 patients, and they found 8. That's half of 1% developed this overlap syndrome in a very carefully studied population where they had biopsies, they had the right response. So it's nowhere near what we're talking about, the 10, 15%. Now, why is this happening? Well, it's happening because of what we've kind of neglected to go back and look at. It was published in 1980 by Christensen. In the graph at the left, if you look at the top line, it shows 231 patients with PBC that did not have treatment. They were trying to give them a treatment. It didn't work. So they had a placebo group, half of them, a treatment group. The treatment didn't work. So they combined the 231, and they did a liver biopsy every year for 4 years on every patient. And they were read blindly. Look at that top curve. By the end of 4 years, 100% of PBC patients had a significant interface hepatitis. It's part of the disease, PBC, when untreated. It is something that occurs in the liver. Therefore, it really doesn't mean you have autoimmune hepatitis. It means it's part of the disease. In addition, autoimmune hepatitis has plasma cells. And plasma cells turn out to be absolutely 100% present in biopsies from patients with PBC alone. So those two criteria don't make this autoimmune hepatitis and don't make it an overlap. So let's turn to first-line therapy. Most of you know what I'm about to say, but I want to add some wrinkles about how we're interpreting the response to first-line therapy. So it's UDCA as your first-line therapy. It improves, as we start at the top, all of your liver tests, your blood tests. And we go to the right, improves your cholesterol and IgM, delays progression histologically, means progression within your liver is seen under the microscope, delays development of esophageal varices, which is a way of saying it delays progression of either cirrhosis or prevents you from moving from pre-cirrhosis to cirrhosis. And finally, it improves liver transplant-free survival, which is, of course, the goal we all have. The dose is important, 13 to 15 milligrams per kilo per day. That's the dose range that we have to target. And it's okay to be a little bit above, but we don't want to be significantly below that range. But if you match up diagnostic codes in the United States with pharmacy records, pharmacy benefits that are covered by specific insurers, you find only 79 of PBC patients in the US are now being treated with UDCA. That is a problem. And I hope to convince you all that we do want you, regardless of the status of your enzymes, to be on treatment. What?
One thing I just wanted to note too, Dr. Vierling put in a few poll questions. So go into the agenda at the bottom of the app, click on this session, Diagnosis and Treatment of PBC, and at the top of that you'll see the 3 poll questions, because it'd be great to show Dr. Vierling, if you're okay, comfortable sharing, how many of you are on UDCA or so, and then also OCA. We'll talk about that later. So sorry. Thanks.
No problem. So this gets me to sort of our newer thinking and its application in clinical trials, which is important to patients living with PBC. The first is that biochemical test results are good surrogate measures for transplant-free survival in clinical trials. That means we don't have to do a clinical trial and wait for people to need a transplant, which could be years to even decades in some, to understand whether the drugs are working. So this is all good news. And many liver diseases don't have surrogates like this, but this one does exist. And what they focused on is this composite endpoint where we use 2 measures the alkaline phosphatase to go below 1.67 times the upper limit of normal and a normal total bilirubin. If you look at that, it's now accepted as a primary endpoint for the obeticholic acid OCA approval in 2016, and it's accepted by the FDA and the European Medical Authority as a surrogate allowing approval, at least conditional approval, for the use of the drugs. Now let's look at the graph. The blue line shows that when you have a normal bilirubin and your alk phos achieves those values, you have the highest long-term survival. This is over 15 years, all comers from a very large database of nearly 4,000 patients. If your alkaline phosphatase is elevated and you have a normal bilirubin, you can see there's a lesser survival. Now, when you look at the bottom, you say abnormal bilirubin really drives these both down, but they're still separated by the difference of those that did achieve less than 1.67 and those that did not. So this is the basis of why that composite endpoint is a good surrogate measure. We're after the blue line. The blue line is essentially this composite endpoint for clinical trials. Now, how do we, as individuals or practicing clinicians, know where we are? Because all of our diseases are different. They're different stages. You've been diagnosed at different times. So we have been working on, and now I think this is the best example of the progress in the field, an indicator of survival benefit on patients who are taking ursodeoxycholic acid. As I told you really got to be on this. And so this is the GLOBE score. And what it does is it measures your age at initiation of the ursodeoxycholic acid. And then 1 year later, what's your bilirubin, your alkaline phosphatase, your albumin, and your platelets. Now, if you look to the right, you see in the middle panel that when your GLOBE score is less than 0.3, the dotted line is the PBC population. They're tracking with the solid black line, which is an age and sex matched population of people that don't have PBC. So you're basically just the same as everybody in the population. If on the right, if it's greater than 0.3, you have a survival disadvantage. You can see that line going down. And this GLOBE score can be calculated by going to globalpbc.com. You just fill in your information from your laboratory tests and your age when you started ursodeoxycholic acid, and it gives you estimates. Those estimates, I think, are going to be useful when we have additional second-line therapies. So to summarize URSO, we know that good response occurs in approximately, and these are all rough approximates, in about 60% of people, and it reduces liver-related deaths and the need for orthotopic liver transplantation. The 40% are non-responders have risk of progression. Now, that may be very slow. You saw some of those curves are actually very slowly changing curves, but it does mean that the risk is that you could progress to cirrhosis, or if you have cirrhosis, it could advance to portal hypertension and the risk of hepatocellular carcinoma, which in PBC, let me characterize, is extremely low compared to cirrhosis caused by other diseases. And that, of course, could result with death of the need for transplantation. So let's look at current and future line second therapies, beginning with the FXR stimulants, which was obeticholic acid, a modified bile acid that decreased fibrosis, decreased inflammation, and led to better bile acid kind of homeostasis and balance. These are the toxic bile acids. So it could theoretically improve all of that. And it was in a trial that was placebo-controlled at 2 different starting doses, where the middle bar, OCA 5 milligrams, the goal was to titrate up to 10. The blue bar, they started at 10 milligrams a day. And they were then moving forward. They used the primary composite endpoint. And what they found, if you look on the left, you see the first 12 months, that was the duration of the study, that 10% of the placebo group met that composite endpoint and 48% of the OCA treated group met the endpoint. Then patients were allowed to roll into a long-term safety extension study, which you can see the months of open label phase. And all patients, including those on placebo, were started at 5 milligrams, and after 3 months, they started up titrating to 10 milligrams on an individual basis. So you can see the placebo group in the open white was now getting response, and these are the data of importance. But equally important was the finding that FXR stimulation causes or intensifies itch, pruritus. That was the principal adverse effect. And that was a serious adverse effect for some people. They could not be managed with their pruritus. They chose to not be on it. So this was kind of a deficit. We found this out in also studies of non-alcoholic steatohepatitis where they used FXR agonists. We didn't know if it was just the fact this is a bile acid or some synthetic molecules would do the same thing, and it turned out they did. And we actually know why, and I'll tell you that in just a little bit. But if we look at information in the real world use, which is global, it's been approved since 2016 with increasing approvals over time in different countries of the world, it had the ability to decrease 15-year cumulative incidences of decompensation of cirrhosis, hepatocellular carcinoma, need for transplantation, or liver-related deaths. It was beneficial in the big picture. But it has an FDA box warning. And that FDA box warning in the middle bullet says you should not use this in patients with compensated cirrhosis and evidence of portal hypertension, decompensated cirrhosis, or any prior decompensation event. And we in liver disease specialists have an inability to know a person with cirrhosis, how close they personally may be to such an event. So we don't have the tools to tell us that, and that gives us great pause because this could have a serious toxicity. That's led to renewed interest in studies I'm going to be sharing the details with of peroxisome proliferator activated receptor agents, PPARs. They stimulate biologically important receptors, and they themselves bind to receptors called delta, alpha, and gamma. And this didn't kind of come, I don't know what to do with the bottom of the slide because they were all together, and this is spaced way out, but I can kind of summarize a little bit. I'm sorry, this slide is not projecting properly. But when you bind PPARs to their receptors, they can change cholestasis. They can decrease toxic bile acids. They can change energy utilization with positive effects on lipids like cholesterol, triglycerides. They can help you with glucose control. They can reduce substantially inflammation, and they can prevent fibrosis. That's a pretty good profile for a drug that we might want in PBC. Now, bezafibrate, which is not available in the United States, is a PPAR alpha only. We have elafibranor that I'm going to share in detail, stimulates the delta and the alpha. And then Seladelpar, I'll share those details too, is a pure delta agonist. So these are the ones that are being used. And finally, seraglitazar stimulates delta, alpha, and gamma. And it's a pan PPAR, and it's in clinical trials right now for the treatment of PBC as a second-line agent. So this has allowed us in these trials and their impacts to start to think about new criteria that we would like our patients to achieve to have the most optimal outcomes. On the left is that we want them to normalize alkaline phosphatase. And you can see that normal alkaline phosphatase in orange has a better long-term survival than being between the upper limit of normal, 1.0, and that 1.67 cutoff. And we also want bilirubin within the normal range to be below 0.6. So let's say our normal range is 1.0 milligrams per deciliter. That says we want this to be 0.6 or lower. Now, a normal woman, adult woman, anywhere in the world who has normal bilirubin metabolism, and there are some genetic reasons that that might not be the case, but if they have normal bilirubin metabolism, the average bilirubin for a normal woman anywhere in the world is 0.4. So this isn't asking the impossible. This is trying to rein it in. And you can see that there are differences in survivals, and therefore we want to optimize. We want the highest normalization of alk phos and bilirubin less than 0.6. Well, let's look at the first randomized controlled trial of the PPAR alpha bezafibrate. It was in French patients, published in the New England Journal in 2018. There's only 100 patients in it. The primary endpoint was normalization of all liver tests: alkaline phosphatase, GGT, ALT, AST, bilirubin. And what they found is they got that normalization in 30% of treated patients, none in the placebo group. And 67% normalized the alkaline phosphatase. The secondary endpoints involved a whole host of things, and I'm not going to go into that detail. And unfortunately, they did have some evidence of fibrate-induced liver injury, which also occurs in the use of Fenofibrate, the only PPAR alpha drug that's FDA approved in the United States, actually for the treatment of elevated triglycerides. The graphs to the right illustrate what I just summarized verbally on the left, and that leaves us into our new players. This is the Ipsen drug, and this is the elative study of Elafibranor with inadequate responses or intolerance to UDCA. So what was done is that patients who did not have their alkaline phosphatase at or below 1.67 times the upper limit of normal were eligible for this study. And we look at the two groups, a placebo group and then oral elafibranor at 80 milligrams. And this went for 12 months. And then they had the opportunity to roll over to oral elafibranor safety extension. A significant improvement at week 52 in biochemical response was seen. You can see that we have 51% of the elafibranor patients achieved normal alkaline phosphatase, the reduction of alkaline phosphatase, and only 4% in the placebo did. So a 47% kind of decrease compared to taking away from the left bar, the placebo group at 4%. If you asked about normalization, they had 15%, 16% in this slide, that normalized, none in the placebo group. So that's after 12 months, 52 weeks of therapy. Their results shown here are the kinetics of this. The top gray line is the placebo group. They didn't really change their alkaline phosphatase. But look how rapidly, by 4 weeks of treatment, the drop occurred on those that took elafibranor, and it was sustained as a drop throughout. So rapidly acting a drug where you know what's happening very quickly. If we look at treatment emergent adverse events, meaning on treatment adverse events, you can see listed there abdominal pain, diarrhea, nausea, and vomiting. Each of those occurred in about 11% of those taking elafibranor, and you can see the percentages varied in the placebo group from about 2% to as high as 9.4%. So it was, in essence, relatively well tolerated by patients, and they reported that, certainly in those that were in our site when we conducted this study. Now, we were blind as to who was on placebo, who was on drug, so we got the composite reports, and it was well tolerated. So that was elafibranor. So here comes the response study. This is the CIMA-BAY study. Now, you may know that CIMA-BAY was just recently acquired by Gilead Sciences, and going forward will be ultimately launched, if FDA approved, by Gilead. Their response study was of Seladelpar. This is the PPAR delta only receptor agonist, and again in patients with inadequate responses or intolerance to UDCA. There's a placebo group, a Seladelpar group. Treatment again, 12 months, and then an open label long-term safety study thereafter. The same endpoint as the Elafibranor study, the same elafibranor endpoint. 20% of placebo patients met that endpoint at 12 months, and 62% of the treated patients met that endpoint at 12 months. When we ask about normalization, it was 0 in the placebo group. It was 25% of patients at 12 months with the Seladelpar group. When we look at the kinetics again, we're looking here for alkaline phosphatase. You can see the placebo group had a little decrement in the gray, but this very rapid fall occurring just as you had seen with elafibranor. This seems to be a class-specific type of kinetics. The PPARs are doing this. Here's a delta. You remember the elafibranor is alpha and delta. This looks at the mean change in ALT, a liver hepatocyte enzyme, and the mean change in GGT. The top light blue is the placebo group. The dark blue is the Seladelpar group. You see, again, relatively rapid decreases and then sort of sustained lowering of these other enzymes, which were part of the secondary endpoint responses. The adverse events that are shown here really started because of when the study was done. COVID-19 was at top of the list because patients were developing COVID and we were picking that up in their reports. Then you had pruritus, upper respiratory tract infections, headache, et cetera. You can look at the percentages there. Importantly, there was comparable safety profile between patients with and without cirrhosis at baseline. About 14% of the study population had cirrhosis when they entered the study. And so it's important to know whether they did as well and they tolerated it as well, and they did. And then finally, I want to share, just to be thoroughly complete, this particular study that Cynthia Levy had headed. It's back in 2011, where they took off the shelf our Fenofibrate, which is FDA approved for the treatment of elevated triglycerides, and they studied it in the same manner using the same concepts of alkaline phosphatase reduction to less than 1.67 times the upper limit of normal. And when these patients were treated, they reduced. When they stopped treatment, which is the last bar on your right, they went back. So it was kind of a proof of principle, and it actually has led to some guidelines saying, well, you know, if you don't have any other PPARs, you might want to consider something like this. But I think that we really have better evidence, and I've just shared it with you, that the new PPARs that have the potential of being FDA approved this summer are going to be superior. So what are the unmet needs for better treatments for symptoms impacting quality of life? You're going to have several talks that will involve this in much more depth. But I want to share with you some of the newer data regarding the impact on pruritus that has been seen in the studies of elafibranor and Seladelpar, because I think it is getting to a very important question about patient satisfaction. It's one thing to say your enzymes say you're going to live longer. It's another thing to say you're going to have better quality of life. That's what we all want, right? We want health to be quality of life, not just longevity. So let's look at pruritus. You all know this, that it's detrimental to quality of life. It occurs in PBC in at least 70% of patients. It can wax and wane, it can be present, it can be absent. And when disease advances to the need of transplantation, very interestingly, even though all the enzymes and everything is worse, pruritus tends to disappear right toward that very end stage. There's no specific medications are able to treat it, although there are those that are authorized for use. It intensifies at night and significantly impairs sleep, and thus even mild pruritus affects quality of life. Now, severe pruritus is illustrated by this terrible set of lesions due to skin scratching that you see on the right, is associated with severe sleep deprivation, social isolation, may trigger even suicidal ideation. And it is an independent indication for liver transplantation where you can get points added to your MELD score simply because you have this severe degree of pruritus, because you need a transplant in that circumstance to alleviate it. Now, pruritus is likely caused by the effects of cholestasis. Remember, cholestasis leads to this upstream retention of toxic bile acids. And we know that because there's rapid relief of pruritus in PBC patients have been observed when you place endoscopically a drain into the bile duct and drain all the bile, take all the bile acids coming down from the liver to the gut and just remove them from the body, as well as when you use charcoal hemoperfusion. Reduction of bile acid concentrations and improved bile flow should reduce pruritus. That's sort of the hypothesis. And interestingly enough, we are now exploring a biomarker of pruritus, and that is plasma interleukin, or called IL-31 levels. These levels are quite high in diseases that are characterized by itch, like severe eczema would be an example. They're closely correlated with pruritus in PBC patients, and therefore they're potentially useful markers. So how do we assess pruritus in clinical trials? The most well-accepted assessment is the numerical rating scale, the NRS. Worst itch measures itch intensity for 24 hours and a 7-day recall periods. And the intensity is rated on an 11-point scale, 0 being none, and 10 being the worst itch imaginable. Now you can imagine when each patient is asked what is the worst itch imaginable, you may have experienced it and you know what that is, but you may not have experienced it, so you wonder, well, maybe it would have been such and such. So there's a little bit of issue about the accuracy at the high end. The 5D itch is a total score from 5 domains, and it has a scale, a domain for pruritus. The PBC-40 itch domain, again, is scoring 6 domains, and it includes this specific itch domain. And all of these have been used in the clinical trials of Elafibranor and Seladelpar. So let me show you the data. Here we look at the numerical response score, and that's NRS. And you can see in the gray is the placebo, in the blue is the Elafibranor treated group. To the right, you see when they looked at the change through 52 weeks, that although numerically it was greater for Elafibranor, it did not reach statistical significance compared to the placebo group. However, when you looked at the PBC-40 itch domain, and on the left, and you look on the right to the 5D itch domain, the differences were statistically significant in favor of the PPAR alpha delta agonist elafibranor. So there was a signal at patients, in addition to getting the biochemical benefit, had a benefit from itch. Now, in these trials, you have to know that we do not have people show up, complain of itch, and do nothing about it. The protocols allow the investigators to treat people for itch. Because we're blinded, we don't know whether the placebo group or they're on therapy. We know nothing about that. We just know we have a patient complaining of itch. So we will deploy, as necessary on a per patient basis, cholestyramine, 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 and other therapies for itch. So it's not as if placebo patients are getting placebo for itch. They're getting treated, and so there's this background noise that we hope in the future we're going to be able to sort out. Let me show you the Seladelpar data. They had in their protocol pre-specified 6 months, and that is shown here as to be statistically significant reduction in the NRS. If we look at the NRS in the overall population, it's on the left, and you can see these are quite well separated from one another. And on the right, you'll see that it was corresponding to this reduction in IL-31. And so it may come to pass, this is a hopeful goal, that in the future, instead of asking about scales and itch, we can measure IL-31 and know what is causing itch, or a biomarker of itch, and be able to design better therapies based on that new biomarker. Again, Seladelpar, the 5D itch total in the those that had a very high itch, intense itch at the top left panel, bottom is the overall population. And now we look at the 5D itch impact on sleep, and you see that sleep was improved. If you improve itch, you'll improve sleep. If you improve sleep, you'll improve quality of life, because we all know what it's like to be tired because we haven't had recuperative sleep. The same thing happened in the intense itch population on the top row and the overall population in the PBC-40 itch. The sleep disturbance was also decreased. So these are encouraging to our field and to all of you as patients. And finally, bile acids are produced in the liver, they come to the gut, they go downstream, and they're reabsorbed, about 95% of them, sent back in the portal vein to the liver. This enterohepatic circulation of bile acid has about 8 to 10 cycles in everybody here in the room every day. We're just constantly recycling. That means that if we can block the ileal bile acid transporters with inhibitors called IBATs, that we might be able to impact itch. And indeed, it is already FDA approved for pruritus in infants with genetic cholestatic liver diseases. And it's in clinical trials for patients with PBC as we speak. And there may be clinical trials that are still enrolling, and you might be personally interested in that if you are experiencing itch. Finally, liver transplantation has excellent outcomes, despite the fact that it can recur in the transplanted allograft. If we look at recurrence, and it does not impact allograft loss after transplantation. You can see at the bottom of the right graph, there's PBC way, way down. And we're looking at huge numbers of days here, well past 10 to 11 years. So let me summarize. The diagnosis of PBC is relatively straightforward and now includes the use of PBC-specific anti-nuclear antibodies, meaning that fewer and fewer patients need a diagnostic liver biopsy. The overlap syndrome is often misdiagnosed. It's not to say it doesn't occur, it does, but we've got to diagnose it with explicit criteria. Transient elastography can detect fat, steatosis, and estimate the fibrosis staging. The primary treatments is UDCA, but effective for the goals of therapy in only 60%. Second line is OCA as the only FDA-approved response, but subject to side effects and an FDA black box warning for hepatotoxicity. Elafibranor and Seladelpar are under review as second-line therapies with potential approval dates this summer. OLT has excellent patient and allograft survivals despite recurrent PBC. Symptoms and quality of life are increasingly important and targets for study, both within the clinical trials for the new therapies, as well as independent trials for specific side effects. Pruritus shows that PPARs are quite promising. Fatigue has been more difficult, and you're going to hear about that in another session. So I'm just going to focus on the fact that PPARs are promising to allow patients to get better sleep, and that may impact fatigue. And finally, phase 3 randomized clinical trials are enrolling. They will have future trials. We're still after the better drug therapy that will normalize your alkaline phosphatase and put your bilirubin less than 0.6 milligrams. So I want you all to consider participation in those trials. Without you, we cannot make any progress. But I do think that if you look at what I've shared with you, that we can say there's a new dawn. Thank you.
Awesome. Thanks, Dr. Vierling. And we did have the poll responses. I don't know if you want to take a look. They're down here as well. But we asked the audience, are you taking URSO currently? Any comments? And we'll queue up some questions. Leslie is going to be queuing up some questions here shortly.
Well, in terms of this, I'm gratified that I told you 79% are not, and that's a national kind of database analysis. The vast majority of you are. I guess the issue becomes for those that are not, what at an individual level could be done to perhaps make it tolerable for you, affordable for you, access whatever. There are a number of issues as to why a person might not be on it. Mm-hmm. But I do wish for a future in which 100% of patients can be on it. Because even if it doesn't achieve these cut points that I've shared with you for optimization, it is always beneficial. For wherever you started, it is beneficial.
Great. And on the next question, we had, Have you ever taken OCA, OCA? You can pull up that next tab. And interesting responses.
Okay, 41% and 59%. Well, you know, this is really, from my perspective, a question that probably has a question buried in it. And I asked it as if you've ever taken it, not are you currently taking it, for a reason. First, the yes, you know, says what I told you, that it would be indicated based on response to ursodeoxycholic as first line in 40% of patients, 41%. So it means it's probably being used in an indicated population. That's my first response. And for urso being 60% effective, for 59% of you it is, and you don't need the second line. So that is very interesting.
So now in follow-up to that, are you
Yes.
taking OCA now?
Now, this was the second buried question. And this is an important one because, you know, not getting into the weeds with individuals and their responses, we know that those that have ever taken it find a variety of symptoms, most often pruritus, to be such that in the long run, they prefer being off it, or their clinicians prefer being off it because they can't find a suitable treatment for the pruritus. Then we have the concern about that box warning. Am I at risk for hepatotoxicity? Or did I experience hepatotoxicity and was taken off it abruptly and appropriately? So I'm not surprised that fewer people are still on it than once took it. But that number, 29%, is telling us that there is, as well as the no, is telling us that there is this need for new and better second-line therapies. And as I say, by the end of summer, they'll be here.
Great. And Leslie, I think you had a question from someone about itch.
Yeah, so one of them, the pruritus blood test. How is the test determined and the treatment level for the level of itching?
Excellent question. Let me go back over that. This is kind of exploratory, and it's coming from basic science of the study of itch in other diseases now being applied and see, is it relevant in PBC? And this biomarker is interleukin-31. It's measured in plasma, so a typical blood test looks at serum. Plasma has to be especially anticoagulated so that the serum doesn't allow blood clotting before it's then tested as a fluid. So a special preparation, and it's not ready for prime time. I'm only sharing with you a hope that we have that further study of this and correlations in individual patients with their own itch scores is going to help us determine, and this is the key issue, determine whether it's going to become a useful biomarker and what threshold would be appropriate to target a reduction to that threshold to alleviate itch. We know none of that yet, but we've never had a biomarker before. And wouldn't it be nice to have a blood test that says, hey, you're near a threshold of itch, maybe we should do X or Y.
Awesome. That's good. Do we have another question or?
How often are ANA-specific antibodies seen in other diagnosis with other autoimmune diseases?
With other autoimmune diseases, there are no reports that they're seen at all. They're considered completely specific. When you look at anti-nuclear antibodies, there are multiple anti-nuclear antibody targets, meaning there are multiple sort of specificities. These are two of them, GP210 and SP100. But it's not associated with other autoimmune diseases in which the anti-nuclear antibodies are present.
Awesome. Great. And we'll have some time later, too, with the doctor's panel. Dr. Vierling will be there to join us.
Yes.
Thank you, and give you a token of our appreciation. Always a stimulating conversation.
Thank you.
Thank you, Dr. Vierling.
Thank you very much.